बिस्मिल्लाहिर्रहमानिर्रहीम इय्याका नअबुदु व इय्याका नस्तईन अल्लाहुम्मा सल्लि अला मुहम्मदिन व अला आलि मुहम्मदिन व बारिक सल्लल्लाहु वसल्लम अलैहि. Dear colleagues, I am Dr. Sultan Ayub, working as a radiologist. This is a male 40-year patient, old patient with history of dyspnoea on walking. So I am going to scan the abdomen of the patient. Here we can appreciate this is the left lobe of the liver, and I have placed the probe at epigastric region. So at this region this is the IVC, and this is the hepatic veins. If we closely observe, we can appreciate that hepatic veins are dilated, and if we appreciate the velocity, the peak velocity is more than 40 centimeter per second, which is higher than normal. And if we observe the IVC on M mode, we can appreciate that IVC is dilated, and there is almost loss of respiratory physicity. That means that with respiration IVC constrict, but here we are unable to appreciate that on respiration, mean on inspiration, the IVC is not seems to be contracted. So this is called loss of respiratory physicity. When this happens, hepatic veins are dilated, IVC is non-responsive to the respiration. It means there is some problem in the right heart chamber due to the backward flow. And it also means that right atrial pressure is increased, and there may be the venous congestion, also systemic venous congestion. So it means that the patient is having some heart problem. We are not going to do the echocardiography, as I am not good in this. However, we can appreciate this one. This is the mitral wall, a posterior leaflet and anterior leaflet, and this anterior leaflet must be very close to the interventricular septum in the usual practice of the normal heart. Here we are appreciating that this is not going close to the interventricular septum. And if we see the M mode to appreciate this, so we can see that the distance from the anterior leaflet to the IV interventricular septum is 26 millimeter. That is more than This indicates the reduced ejection fraction significantly. Uh, Again, I'm telling you that I'm not good at echocardiography. So, only I want to tell you that when we appreciate the non-responsive IVC, which is dilated also, and the hepatic veins are dilated, we should also know about the cause of this thing, what is going to be going to something wrong in the heart chambers, and then we should also focus about the right heart chamber. When we are going to examine the right heart chamber, we should also have a look on the left heart chamber. So both we have seen that right heart chamber or right atrial pressure is increased with systemic venous congestion due to this due to the findings of non-responsive dilated IVC, dilated hepatic veins. And when we see the mitral leaflet, they are not going to touch the intraventricular septum, which is seen in the normal functioning heart. So it means that systolic dysfunction is also present. So this was somewhat about this finding which we have seen. So now I am going to see other things. Any other problem, as the patient is 40-year age with history of dyspnea last 2-3 years. And here we can appreciate the this is the right kidney, which obviously we can say that it is small in size, and we appreciate this echogenic line all around the kidney. Look here, this echogenic line is involving the cortex of the right kidney, which is small in size. I'm going to see the left kidney. Here we can appreciate the left kidney. This is also left kidney, which is also seems to be small in size, and this echogenic line is also present all around the cortex of the left kidney. So for the better picture or visualization, we can use the linear high frequency probe. So here we can appreciate this is the cortex of the left kidney, and these are the echogenic lines which we are appreciating with the convex probe. Here we can appreciate this is the calcification within the cortex of the kidney. So we can say that this is cortical nephrocalcinosis. This term is used radiologically or sonographically, the cortical nephrocalcinosis. So this is the cortex, or also there is the thinning of cortex, and also the cortex shows diffuse calcification. So we can say that this is cortical nephrocalcinosis that is involving both kidneys, and both kidneys are small in size. When this happens, when the kidneys are small, here we can say that this parenchyma is showing calcification. It is not hyperechoic, which we say that loss of corticomedullary differentiation, we use the term. This is not that case. Kidneys are small and they are showing calcification, diffuse calcification involving the cortex of whole kidney bilaterally. This is the calcification. So what we have seen that we have bilateral small kidneys having nephrocalcinosis, and also there is a passive hepatic congestion characterized by the dilated hepatic veins, non-responsive dilated IVC. So this is the whole findings in this 40-year male patient. Minimal ascites is also present. We can appreciate this one. So in my opinion, this is the case of renocardiac syndrome with chronic kidney disease, having bilateral small kidney with nephrocalcinosis, and also the congestive cardiac failure. I have seen the left heart chamber and right heart chamber, both are dilated, and ejection fraction is significantly reduced. So this fellow is also having cough. Now I am listening. Look here, the picture of the nephrocalcinosis. This is the left kidney. This is the right kidney. One thing we have seen many times that there is a medullary nephrocalcinosis, means calcification within the pyramid. This is the pyramid. This is the pyramid. So these are not having calcification. This is the cortex. This is the cortex, which is having calcification. So this term is used, nephrocalcinosis. Here one more thing I want to show you. Here we can appreciate these echogenicity lines. This is the periportal increased echogenicity. This also indicates the periportal hepatic edema. In the passive hepatic congestion, we can also appreciate the gallstone. Now, this one. and also we can appreciate the gallbladder is diffusely and mildly thick wall. So this is due to the passive hepatic congestion. So this was all about the case which we can say that this patient is having chronic kidney disease characterized by the bilateral small kidney and bilateral diffuse nephrocalcinosis that is associated with the congestive cardiac failure. Thank you very much.